Good afternoon, everyone, and welcome. My name is Melissa Mueller, and I am DWDC's Program Specialist. I'm joined today by my colleagues Kelsey Goforth, Director of Programs, and Amanda Coventry-Barrage, Program Director. Before we begin, I want to acknowledge that while we are all meeting virtually, the land Dying with Dignity Canada is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Indigenous, Inuit, and Métis peoples. We acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. We invite and encourage you to do your own research regarding the various treaties, in particular the land in which you're meeting with us today. I'm thrilled to welcome you to the first session of Dying with Dignity Canada's Learning Centre. Through this series, we aim to provide comprehensive information on several topics related to death and dying. By attending the 5 sessions over the next month, you should gain a thorough understanding of the issues that matter to you. If you haven't done so already, all sessions and their registration links can be found on our website. We are putting a link for the next session on MAID and capacity in the chat. Before I welcome today's presenters, I'd like to go over a few housekeeping items. Everyone on the call today is muted. However, there will be opportunities to submit questions. To do so, please type your questions in the question bar on the Zoom side panel, and we'll read it out for you at the end. Please try to keep your questions as concise and clear as possible. Sorry about that. Okay. While we are going to have as many viewers as possible answer your questions, unfortunately, we may not get to everyone. If you have any outstanding questions following the webinar or questions that are quite personal in nature, please contact us at support@dyingwithdignity.ca, and we will follow up with you individually. We will be sending a post-webinar survey that will pop up on your screen after the webinar. It will give you the opportunity to share your feedback, and this session will be recorded, so you will be able to watch it again later. So there's no need for you to take notes if you choose not to. I now want to introduce today's speakers. First joining us is Dr. Chantal Perrot. She's a MAID assessor and provider in Ontario. Dr. Perrot is a member of Dying with Dignity Canada's Board of Directors. She is also chair of the Board of Directors of MAID House. She is a member of CAMAP, which is the Canadian Association of MAID Assessors and Providers, and moderator of the CAMAP MAID Providers Forum. Also joining us today is Dr. Sandip Singh Gandham, who is a MAID assessor and provider in Alberta since 2016. He completed his Doctor of Medicine at the University of British Columbia. He currently has a mixed practice in Edmonton. 70% is clinical and includes long-term care, addiction medicine, and he is a hospitalist in patient care. And 30% of his practice is leadership as a provincial medical lead for MAID in Alberta and a medical director at a few long-term care facilities. I will now turn it over to Kelsey to get us started.
Great. Thank you so much, Melissa, and thank you to Sandip and Chantal for being with us today. As you know, today's topic is MAID eligibility, and we hope that from today's session, our audience can gain a better understanding of what goes into an assessment and what clinicians are considering when meeting with those interested in MAID. Today, we'll be discussing 4 examples, and these examples will be profiles that include things like age and medical conditions, but they are entirely fictitious and not based on any real person. Our presenters today will be discussing how they might approach these cases and the factors they would investigate as MAID assessors. It's important to note that everyone's situation is different. So if you are interested in being assessed for MAID eligibility, an assessor would need to consider your unique experiences and the factors that you're going through in your life. So this webinar is designed to give some insight into the assessment process and how eligibility is determined, but the only way to determine your own eligibility is to be assessed by a nurse practitioner or a doctor. So I'm going to turn it over to Chantal now, and she's going to take us through a bit of an overview of MAID eligibility to get us started. Go ahead, Chantal.
Great. Thank you, Kelsey and Melissa, for organizing this. And thanks to everybody for being here. I hope you'll get some good information, and I look forward to lots of questions at the end. So I'm just going to go over a little bit about MAID eligibility, but before I do that, talk about the purpose of a MAID assessment in general. Really, the purpose of the MAID assessment, the purpose of me meeting with someone to do an assessment for MAID is to determine whether they're eligible to receive medical assistance in dying. And that would mean that they meet all of the eligibility criteria as laid out in the criminal code. But the focus of the assessment interview is really twofold. The first one is really for me to get to know the patient as much as possible, who they are, what's important to them, the values that have guided their life, and so on, and then to focus on asking questions that would fill in the other necessary information so that I can determine whether they meet the eligibility criteria. So I'll just go through those eligibility criteria themselves. The first is you have to be eligible for government-funded healthcare in Canada. Canada does not have medical tourism for MAID at this point. It's only people who live in Canada are eligible for MAID. Person has to be 18 years of age or older and have decision-making capacity. Next slide, please. They have to have what's called a grievous and irremediable medical condition, which means they have to meet all of the following criteria. They have to have a serious and incurable illness, disease, or disability. And up until March 17th, 2023, this excludes a mental illness as the sole underlying condition. They must be in an advanced state of decline and capability that cannot be reversed. And they have to be experiencing unbearable or intolerable physical or mental suffering from an illness, disease, disability, or the state of decline, and that suffering cannot be relieved under conditions or with treatments that the person themselves considers reasonable. And I always emphasize that it's according to the person themselves, not according to me as an assessor or other physicians or nurse practitioners that the person may meet or the person's family. It's up to the suffering is defined by the person themselves. The person also has to have made a voluntary request for MAID that was not the result of external pressure. And we do check very carefully for that because people should not be coerced into receiving MAID. And a person has to give informed consent to receive MAID after having received all the information needed to make the decision, including a medical diagnosis, available forms of treatment, and options to relieve their suffering, including but not limited to palliative care. Next slide, please. So I'm going to review the case of Lily. Lily is a 75-year-old woman who is married and has 2 adult children. She was diagnosed with Alzheimer's disease about 2 years ago. She's on statins for cholesterol. And if anybody knows what a statin is, it's a medication that's used to lower cholesterol, and cholesterol is usually implicated in heart disease. And Lily enjoys an active life, traveling and hiking. So what do I do when I call Lily and go to meet with her? Now, often when I get a referral, I'll get a little bit of skeletal, sketchy information about the person, sometimes nothing at all, but usually just a few details like I've just described with Lily. So I start thinking about, before I meet with them, what are the kinds of questions that I'm going to ask them? What's going to help me to do the best assessment I can for them? So the questions that I would look at guiding my assessment of Lily would focus on her social and personal history. I want to get to know her and what her life has been like. I'd look at her medical history. How advanced is the Alzheimer's? What's the impact on her capacity? What's the impact of the Alzheimer's so far on her life? How well is she able to take care of herself? What's the cardiovascular risk disease that she has that's leading because with her cholesterol being high? And does she have any other medical conditions that would contribute to her suffering or to her illness, her overall condition? I want to understand her request for MAID. How did she find out about MAID? Is the idea of an assisted death part of her long-term values, principles, something that she's thought about over the course of her lifetime, or is it something she's just learned about and is exploring? I want to understand her experience of suffering. What does it mean to her? What is it intolerable about it for her? I want to very carefully assess her decision-making capacity, because with Alzheimer's, there are different parts of the brain that can be affected and different ways of cognitive processing that can be affected. I want to make sure that she really understands what she's asking for and has the capacity to answer the questions and to provide informed consent for MAID. in further kind of exploring her experience of suffering, I want to talk to her and let her know that at some point in the dementia process, people often no longer are suffering. And so it's not uncommon for someone who lives with dementia to actually seek medical assistance in dying before they lose that capacity. And unfortunately, at times people lose the capacity to make that determination because they really are no longer suffering. And they no longer even think about MAID. They're just kind of, their brain function has decreased to the point where they're living and existing, but not in the same way that they were before. And so I want to tell people about that so that they can make a more informed decision. And a question that I'll ask people at times is, has the burden of living exceeded the joy of living? And that's a way that people can sometimes get at some of the underlying suffering. And again, with somebody with Alzheimer's, I want to make sure that it's a voluntary decision, that they have the capacity to make the decision. And one of the things I also explore for somebody who may have multiple caregivers in their lives is their caregiver burnout. Is somebody concerned about their caregivers who are taking care of them burning out and not being able to take care of them any longer? Or are they concerned about being a burden on the people that they love and care about? And if so, how might all of that be contributing to their condition? I also want to explore for their financial situation. Are they able to afford the kind of care that they need? Because often if someone has dementia, they're not able to live on their own without extensive help and caregivers, and that's not inexpensive. Next slide, please. So after I go through and get all of that information, the questions that I have to ask myself are, does Lily qualify for MAID? Is she eligible for health services? If she's living in one of the provinces or territories and she's a resident, then she is. Is she 18 years of age or older? Yes, we know that she is. Is her request voluntary? So again, I will have asked her a lot of questions to make sure that she's not being coerced or pressured to receive MAID. Is she able to provide informed consent? Does she understand what MAID is? Does she understand that receiving MAID means that she will die with the medications that are given to her in the course of MAID? Does she have a grievous and irremediable medical condition? She does have a serious and incurable illness, disease, or disability because she has Alzheimer's disease. Is she in an advanced state of decline and capability that cannot be reversed? Well, Alzheimer's cannot be reversed. And if she's no longer able to live on her own or no longer able to do some of the things that she would need to do to maintain her existence, then she would be considered in an advanced state of decline and capability. Is she experiencing unbearable physical or mental suffering that cannot be relieved under conditions that she considers acceptable? Again, I would need to explore that with Lily in detail and find out what her experience of the suffering was. So if she was found to be eligible, does she have a reasonably foreseeable natural death? And with a diagnosis of Alzheimer's, yes, she does. The average lifespan for someone diagnosed with Alzheimer's is less than 10 years. So she would be eligible under what we call track 1 with a reasonably foreseeable natural death. And I think I'll stop there.
Thank you, Chantal. That was very, very helpful to get a sense of how you would approach a case like Lily's. Just a couple follow-up questions. So when you're determining capacity for somebody with a dementia diagnosis and trying to get informed consent, are there specific tools used? I know there's talk about like different medical scales and the MOCA scale and things like that. Is that something that's commonly referred to when assessing somebody with dementia, or are there other ways of doing that?
You know, I don't generally use the scales because they're more for a global cognition. And the assessment for MAID is what we do is what's called decisional capacity assessment. So I need to know that Lily can make the decision to choose to have medical assistance in dying. She doesn't need to be able to balance her checkbook. She doesn't need to be able to draw a clock and put all of the numbers in the hands of the clock. And there are a lot of things that she doesn't need to be able to do, but she does need to be able to understand what medical assistance in dying is and what the request for it means. So my questions in exploring with her and in talking with her, you know, by the time I get to specifically thinking about the capacity assessment part of it, she's already answered a lot of questions for me. And if she's been able to very fluently answer questions and give me detailed history about her life, then that gives me a good understanding that she has an understanding of my questions because she's able to respond appropriately. And then I will ask some targeted questions specifically about medical assistance in dying and the understanding of death. And sometimes that gets into a philosophical conversation about what is death, what is the meaning of death. You know, I'll ask people what happens when you die, and they'll say, well, you're no longer here. I say, well, if you die today, are you going to wake up tomorrow? And often they'll laugh and say no, and say, well, where will you be? In heaven or something like that. And how long does death last? Well, death is infinite. So those are the kinds of things that I'm looking for. If I ask somebody if they're going to die today and if they wake up tomorrow, or I ask them, what are you going to do tomorrow? If they start to talk about activities that they're planning to do after they've received their medical assisted death, then I have to really explore that more and carefully appreciate whether or not they understand what death is and what medical assisted dying is. So again, there are different levels of cognitive change that happen with Alzheimer's. And so somebody can be in an early or even moderate state of dementia and still be able to make the decision to choose medical assistance in dying.
Mm-hmm. Yeah, I think that's important for folks to remember that it's situational. You might not be able to do something checkbook example that you used to do, but that doesn't necessarily mean that healthcare decision-making piece isn't there. Yes. Another question, you mentioned earlier on, I don't know if it was in relation to Lily or just general eligibility piece, but addressing when somebody feels as though they might be a burden and exploring that with somebody. How do you do that? And if somebody does have a response about feeling like a burden to their loved ones, how does that conversation get explored more?
Well, I think it's important to recognize that most people don't really want to be taken care of by other people. They'd rather be able to live independently and take care of themselves. And so part of it is that sense of loss of autonomy, loss of dignity is very difficult for people. And then they also think about, these people have to take care of me. I need these people, whether it's family and friends or caregivers, I need these people in order to exist. And that puts a burden on people who, if it's family or friends who are taking time away from their own lives, or time away from work, depending on how intensive the care needs to be. And they often feel badly about that. And I think it's important to empathize with them about that, and also to reassure them that the people that are caring for them because they do love and care about them. And it's not easy to be a burden on somebody else. And that's sometimes the role that we do have to live with.
Thanks, Chantal. So we're going to turn it over to Sandip to go through his case. But before we do, Sandip, did you have any comments on Lily? Anything that you would like to add, or additional things that you would do when assessing somebody like Lily?
Yeah, no, for sure. Thanks. I think the general framework for all MAID assessors is pretty similar. Everybody has their own little style that they bring in, their own experiences, slight nuances, but the general steps that you go through are pretty similar. And I would have a very similar approach to Dr. Perrot here. I think one thing that's also important to sort of mention, we talked about capacity, and it's sort of time specific and topic specific, and it can fluctuate a lot. And especially individuals that are older with dementia, you have good days, bad days. So when we do assessments, often we try to hope to get them at, when they're able to present their complete and full self, their best opportunity. So sometimes that means it may be multiple visits. Sometimes it may be catch them one day afternoon, they're not having a good day, they're better in the morning or evening. So it may involve multiple visits. So it's good for patients to know that if they feel they weren't able to get all the information, there's ample opportunities. It's not like a one-time go interview, either you pass or you don't. So you're going to give the patient all opportunities to sort of get their story out, as I was kind of saying, as Dr. Perrot was saying, getting their whole life story and currently what's going on with them, right? And the only other thing I think it's also, mentioned about the burden. I think it's also important to think when you're looking at that burden, where is it coming from? Is it actually coming from the patient's own perception that they feel their burden, or are they almost feeling compelled that they're burdened from other people, like from staff, from family members, which sort of goes back to that voluntariness request. they still want to go on, but they're feeling that they're been told they're a burden versus their life is sort of complete and they're feeling they become a burden. So that's also little things that come out when you're sort of talking to them.
Thank you. That's helpful as well. Alrighty, well, we'll move along with our next case and get the next slide up. Perfect. Go ahead, Sandip, whenever you're ready.
Case 2 here, Jaden. He's a 45-year-old gentleman here, single, close with parents and older brother, diagnosed with ALS 2 years ago, has experienced significant decline over the past 6 months, has experienced mild depression for 6 years. He's been on some treatments for that depression, including therapy, as well as some medication. So one of the common types of medications that are used are SSRIs, those antidepressants. Next slide, please. So the similar approach, so when we're going through their, gathering the information beforehand, looking through their chart, and then ultimately setting up that initial interview with the patient. So when you're going through that, in terms of, step by step, you're looking at the eligibility piece. The first part for health services, obviously, if, as mentioned, if they're residing in Canada, they're eligible for health services. Age, in this case, obviously they're adults, 18 years old. The request here, so again, when you're talking with them, making sure again that this request is coming from them, that there's no outside pressures that are being put on them, either directly or indirectly. And often this is sort of not just a single question, but in an entirety, when you're sort of talking to them, assessing them, finding out, part of this is also why they're requesting it. That helps you assess the voluntariness of it. So essentially, when it comes down to, especially somebody that has a mental health illness, that wish to die, where is it coming from? So, one thing, 2 points to remember. One, having a mental health illness itself does not automatically exclude you from MAID. So you can have some sort of advanced disease, like a neurological disease like this, and have a coexisting mental health illness. But as long as the decision is not solely coming from a mental health illness, that there's no other illness going on, the person would still potentially be eligible. So in this case, one of the important things to sort of, you want to moot out when they do have a, depression existing, it said it was mild, you want to sometimes have discussions with that patient themselves. And sometimes if after that discussion it's still not clear, you might look at other assessments that were done if they were seen by a therapist or psychiatrist. And if it still remains sort of unclear, in some cases, getting a specialty assessment from a psychiatric specialist, if it feels that might be helpful, that might be included. Sometimes you're able to sort of mesh it out yourself. So in terms of mental health, when we're talking about the request to die, one of the key differences is you want to see that wish for somebody to die, is it actually due to the suffering, which is a result of the illness, or sometimes the wish to die can be a component of the illness itself. So somebody that has severe depression, or that hopelessness, that not wanting to go on because of the illness. So talking about that, seeing where it's coming from is important. And one of the things that helps you decide that is when you're looking at that request, is it something that's been consistent over time? So is this something that the person just recently requested, or is this something that they've expressed in the past, either to other healthcares, to family members? And sometimes the patients will tell you directly, oh, I've been thinking about this for some time. And other times, with the patient's permission, I'll often ask them, is family aware of the decision? And would you like them to be aware? And sometimes they've had those discussions. If not, I'd offer to be a mediator to help engage in some of the discussions. And some patients are wanting to, some people want to keep it to themselves. But if the family is involved, then getting that collateral sometimes can be helpful. And family members can often say, oh, yes, my loved one, in this case, somebody that, that's been declining for some time, they've had this thought and request for MAID expressed at quite some time. So that this is sort of an enduring request, that this isn't something made in haste. So that helps you with that as well. So going back to that qualification here. So again, the informed consent. So as long as they, the key pieces here, do they understand their illness, the natural course, the treatments available for it, what would happen if they took them, if they engage in those treatments, and about the MAID itself, do they understand what MAID is, the consequences of MAID, as kind of pointed out, that, what would be the consequences if somebody did engage in MAID. So in this person, you want to have that capacity assessment as part of that, and if they are capable. And then going on to that, that fourth criteria, that grievous and irremediable condition. So in this case, is it a serious and incurable illness, disease, or disability? So ALS definitely is. It's something that progresses with time. It can vary time course, but some people can progress very rapidly, as was the case in our case here with Jaden. Are they in advanced state of decline? So you've seen that, it's expressed that the person has declined. So getting sometimes a bit more detail from the person. So in this case would be things like, what were they able to do before? Were they able to do the basic activities of life, sort of like grooming, transferring, toileting, feeding themselves? Have they lost the ability to do those things? Are they relying on others to do that, family members or caregivers? So, and, is that decline something that's permanent, temporary? In this case, with the ALS, it would be assumed to be a permanent decline. So they would meet that criteria. And finally, that suffering component, that physical or mental suffering. And, for some individuals, it may be entirely physical. Some may have a mental suffering. And for many, it may be a combination of both. Looking, are they suffering? And again, the key point here is from the patient's perspective, the suffering for them, which one person finds suffering, another may not, which is fine, but does the patient find that suffering? And is it intolerable or unbearable despite the available treatments available? ALS obviously has limited, we don't have any cure for it, but in treatments that would include supportive measures, so things like occupational therapy, physiotherapy, have they been offered that? Have they tried it, or have they declined? And or do they find that any of those measures are acceptable, and what was the results of those? And then finally, in this person, is a death reasonably foreseeable? With ALS, when you have that sort of a rapid decline, it tends to progress to other bodily organs and ultimately to the respiratory system. So yes, they would have a reasonably foreseeable death, in which case they would fall into the track 1. So ultimately, this person, would meet the criteria based on this, but of course, you want to make sure those factors that we just talked about.
Great, thank you so much. And just, we had a few people writing in looking for a bit of a reminder about track 1 and track 2 and reasonably foreseeable or not. Could you expand on that a little bit for folks who need a bit of a reminder?
Sure, that's a good question. So, there isn't a clear-cut definition. So when if you look at the legislation, they talk about reasonably foreseeable natural death. There's been some sort of discussions, and I know the CAMAP group has been working extensively on this, developing a consensus on this, and various assessors that experience in this, weighing in on this. Essentially, foreseeable death, reasonably foreseeable would mean that the person's death, you could predict that it wouldn't be a surprise, it wouldn't be something unexpected in the coming future. So that doesn't necessarily mean days, it can mean weeks, months, and for some cases it can mean a couple of years, but we're not talking multiple long years. We're not talking like 10, 15 years. In those cases, previously, those would not apply to MAID, but with that new legislative changes that came into effect last year with the Bill C7, those people whose death is not foreseeable, so again, those whose death is many years into the future, they still could be potentially eligible, but they would fall under this track 2. So there's a couple of extra, the criteria are still the same, but there's a couple of additional safeguards that are for these individuals to make sure that their request is sort of in keeping with the spirit of MAID.
Thank you. Chantal, two things for you. Anything to add to the discussion on track 1, track 2, reasonably foreseeable, and then anything to add to Jaden's case and eligibility and how you might approach his case?
I think as Sandip mentioned, the eligibility or the assessment process is relatively similar probably for all of us. We all have our own ways of approaching it, but we all have to get the information that we need to get in order to determine whether someone's eligible. So I don't have anything particular to add about the assessment for Jaden. In terms of the reasonably foreseeable, or the track 1 versus track 2, the additional safeguards that are in place for the track 2 patients, those whose deaths are not reasonably foreseeable, are really to give the assessor and the patient a chance to understand all of the different possible supports or treatments that the person might be able to get access to. And a person does not have to accept any medical treatment that they do not want to, but they, in order to give informed consent and to give an informed refusal of something, they actually have to know about it. So it can sometimes take a bit longer to do these assessments when it's a track 2 situation, because there often are other treatment considerations that we may not all be familiar with. And so we have to find that out and present those to the patient. And sometimes that means that if we don't have expertise in the condition that the patient has, then we have to seek out somebody who does have that expertise and consult with them, and sometimes even have the patient meet with them as well. And in terms of how do you decide which track it goes on? I mean, I think it's a clinical decision, and clinicians do approach this differently. Some people look at reasonably foreseeable natural death as being only within the next months or a year, more like a terminal condition. And others, particularly those of us that learned from the AB case in Ontario, which happened in 2017, that it is a clinical decision. And if someone is on what we call a trajectory towards death, if their condition is something that ultimately is going to lead to their death, that they may be eligible with the reasonably foreseeable natural death, even if their death might be 10 or more years out. So it just depends on the situation and the comfort level of the assessor.
Yeah. All right, so we'll move on to our next case. We have Rosa and we have Sandip taking us through Rosa's case.
Sure. So Rosa here is an 87-year-old woman. She's widowed. She lives in a retirement community here. Currently, she's requiring assistance with bathing, but she can use a toilet on her own independently. She was diagnosed with arthritis some 20 years ago, and currently her treatment for it consists of using some pain medications in the form of Tylenol coatings with Tylenol 3s for that. Next slide, please. Next slide, please.
Oh, Melissa, is your computer okay? Or do you want me to?
Well, we can, while we're switching there. So essentially, we're going to go through that same kind of process here, looking at Rosa's assessment here and considerations of her MAID request. So one of the things to look at here, apologies for those that are tuning in, some technical stuff, but we'll still go through a lot of it, is verbal, and I'll go over the slide. There's not much on there. Thank you. Is looking at age. So, some people might look at, is age alone a criteria? She's older, but keep in mind, it's not necessarily by itself, although yes, age, when you are advanced age, you can be. There are many people, again, this comes down to individual assessment and the situation, but that are very functional. There's I know there's a case of this individual in England, this Waiver Singh. He came there in the 80s, and he was running marathons in the late 80s, and he ran his final marathon, I think, at the age of 93 for 6.5 hours. So some people are highly functional, able, enjoying life. So age, advanced age by itself wouldn't sort of automatically meet it, but certainly it would make you closer to foreseeable death. The other thing you want to look at here, especially with elderly patients and in people that are having decline, is what we call the activities of daily living. So these are essentially the basic activities, necessities that you have in a day-to-day life. So things like transferring, mobility, grooming, hygiening, eating, feeding yourself, looking at that with her. So, she has some loss in some of those for the bathing, but she can use the toilet. So you want to see the other things. Are they still able to do them? Is she needing assistance for that? And this is important because the ADL kind of gives you a general overview about the person's overall cognitive and physical functioning. When there's loss of many of those, it kind of correlates with more of a significant decline versus a very little decline when the person's able to maintain most of those activities on their own. In terms of the social here, the person's living in a retirement community, so on their own. It's in a situation like this, I often, ask them, who is their social network? Do they have family still? Are the family involved in their life? Are they involved in the care at all? Are they aware of the MAID request? Again, they don't need to be, but sometimes, we always offer about that discussion. Sometimes it is helpful. Sometimes some family members find it difficult. They don't know how to bring it up. And would that, especially in this case, influence the person, because when you're living, here, you want to understand, for everybody, the motivation behind the request, what's leading to it. Is there some element of, social isolation, loneliness that's going on, potentially a mental health factor that's going on here? Many people can feel lonely and depressed. So you want to root that out. And then when you're going through their medical history here, one of the things you want to look at, especially with people that are in advanced decline, older as well, is something, frailty. So frailty is a term we use in medicine. Is not a specific individual, focused diagnosis on itself, but it's sort of a constellation, a syndrome of symptoms where, a person has had overall physiological decline, and then they become very vulnerable to, even the simplest of medical or, physical events that can happen and cause, extreme adverse outcomes. So, so things like somebody who's, it's a scale that we have here in Canada to use. We have this Canadian frailty scale. It kind of goes from somebody being very fit and able-bodied, so they can do everything on their own, walking, they're doing their own grocery shopping, living on their own independently, no home care. And it kind of goes down stepwise as they lose those activities of daily living we spoke about. They need a little bit more support. They might need some home care, all the way to the point where they're extremely frail, where they're, bed bound, they're needing full support, 24-hour nursing care. And in those situations, the person, becomes very susceptible even to minor things like a cold, a flu, or fall. It can have drastic outcomes. So having that frailty assessment can really help determine the person's eligibility and also in which track the person would go under. And then finally, again, going back to that sort of, motivation piece, that request, understanding, would those things, change their request for MAID if certain things were met. So living in this retirement community for Rosa, it's not clear, is it a, assisted living, supportive living, depending on where you live in, or is it like a nursing home, long-term care where you have full supports? Maybe there's, would her position change if she had additional supports available to her that's just lacking? So really, or is that she's realized that, she's lived a complete life, she knows where she is in life, and that this request for MAID is not just based on, it's not based on resources, but feeling that, her life is full, she's complete, and that the person really is realizing that the decline is, rapidly progressing, and they don't want to continue like this to the point where they become completely dependent on others or bedbound. Going to the next slide, please. And then, so going quickly through the, the qualifications for MAID. So again, eligible for health services. In her case, yes. Canadian resident, is a Canadian citizen, eligible for services. Is an adult over 18, yes. Is it voluntary? Again, looking at this, talking to her, finding out that is their own request, no pressure, outside pressures from anybody, including in her case from the facility. Is it informed? So just because somebody's old doesn't necessarily mean that they lost capacity. Again, capacity is individual, everybody's assessment. It's decision specific and time specific. So making sure that she is able to provide that informed consent after you talk all about her medical condition and MAID. And then going through that grievous and irremediable condition, does she qualify? In her case, the arthritis here is the main thing. You want to make sure, is the arthritis just limited to one joint, or is it sometimes arthritis can be quite widespread, all over in the spine and multiple joints and sort of beyond repair, in which case it would be irreversible, severe. So are there other medical conditions going on, including, we talked about that frailty, advanced frailty. And so in her case, potentially it looks like she would meet that, but you want to make sure. Advanced state of decline, again, her functioning, going back to her activities, what can she do, what can she do, and has she been offered those additional supports? And if she hasn't, once you talk about them, does she want to engage in them, or does she find that they are acceptable or not? Again, it's all based on the patient's own understanding and their values and beliefs. And then finally, is her death reasonably foreseeable? So again, this is a whole thing taking into multiple factors, their medical condition, her age, her frailty. So in her case, somebody who's 87, with the decline already in activities, physical capacities, and likely some degree of frailty, she very well, her death could be reasonably foreseeable. Again, this is something you would kind of pan out with further conversation with her, but just on initial kind of exam, it looks like she probably would qualify for the track 1 in this case.
Great, thank you. We got a question. It doesn't necessarily apply to Rosa's case, but it certainly could. This person's wondering, once somebody has been assessed and approved, is there a time limit on when they can move forward with MAID? Is there a limit on their, or expiry on their request?
So, it's another good question. So there's no formal expiry. Once you've been assessed and you've been found eligible, it's up to sort of that would sort of be the follow-up thing with the patient. Okay, now sometimes it's more of a, they want to be sure that, as they decline, they reach a point that they're been qualified and that they can engage at that point. So some people want to put it off for some time, saying, okay, what, not just yet. There's something I want to do, or some things I want to attend. I still, whether it's somebody's graduation, a wedding, or before that, whereas others want to do it very quickly. So there's no specific time limit per se. One thing to keep in mind, though, is if there is going to be some gap in time from the time that they were assessed and to the time they eventually want to proceed, the person is going to take into account, so the provider, that nothing has changed in the person's condition. So specifically to do with capacity, is the person still able to understand what they requested? Are they still able to, express that same desire to go through with MAID? And as well, in the track 2, there's going to be that 90-day limit. So that's a minimum period, but not in terms of how long the person can go. So it can go on as long as there's nothing significantly changed in the person's ability to give that same consent. One thing to sort of keep in mind with that is there are individuals that that worry that they might lose consent. They want to sort of have this done, and so if they lose consent, they can still go through with MAID. So for those that fall into the track 1, so those whose death is foreseeable, and that there's worry from the patient and the clinicians that this person is at risk of losing their capacity, they can sign this waiver of final consent. So typically the person has to make a request initially to start the MAID process, and then once the day of the MAID process is happening, there's confirmation done again from the assessor that the person still hasn't changed their mind. So this second thing, request to confirm, can be waived for those with track 1. So that's something to keep in mind. But in short, there's no time limit per se.
Great, thank you. And if anyone has questions about the waiver of final consent, we do have some information on our site, and you're welcome to email us at support@dyingwithdignity.ca. Not everybody is eligible to have a waiver of final consent, as Sandip said. You do need to be on a certain track, and it has to be done with your MAID provider. It's not something that you just do on your own and have, you know, sitting there. It is something that you do with your provider. So we do have information on the site about that in more detail. Chantal, anything to add about Rosa's case before we move on to the final one?
Nothing about Rosa's case, but just in general about the process. And I look at the MAID assessment process as a process that goes on. It's not something that necessarily gets done in 1 or 2 meetings with the patient. So, for example, many patients will find that once they're found to be eligible for MAID, they actually don't want it right away because they experience such relief that they have a kind of renewed sense of good feeling, or their suffering is mitigated to some extent because they've been found eligible for MAID, and they don't need to proceed right away. So I often will tell somebody that I think you are eligible now, and you let me know when you want to proceed. And, you know, I keep in touch with them. Sometimes it's weeks or months, and sometimes it's even been a couple of years. And that doesn't mean that the person was not eligible in the beginning, but they were eligible, but they've decided that they're going to live with whatever condition they have, or because they with the relief that they've gotten, knowing that they can have MAID, that they carry on. So I don't actually complete the assessment until they're closer to the time that they actually do want to proceed with MAID. And like I said, I would keep in touch with them over that period of time, just checking in with them periodically. And another point about this waiver of final consent, that some people may be eligible for MAID, and they may have the cognitive capacity to provide informed consent for medical assistance in dying, but they may not have the cognitive capacity to understand what a waiver of final consent is, because that does require a higher degree of cognitive functioning. And so sometimes, you know, somebody could be on track 1 and eligible for MAID, but they're not able to do that waiver of final consent because their cognitive function has already declined to the point that they can't quite grasp and understand what that is.
That's a good point. All right, we'll move on to our final case, and lots of questions coming through. So please keep them coming, folks, and we'll try to get to as many as we can at the end.
Okay, so the last case is Joseph, who's a 40-year-old man who's married with 1 child. He was diagnosed with complex regional pain syndrome 7 years ago and has tried numerous medications and therapies, including ketamine, physiotherapy, Botox, and probably a whole bunch of other ones. Complex regional pain syndrome is a nasty condition, and it's people live with extraordinary pain, and there's no clear underlying diagnosis or reason for that pain. So the next slide, please. So the questions that would guide my assessment of Joseph, again, would focus on the social and personal history. What are the principles and values that have guided his life? What has been meaningful to him in his life? What's important to him? In terms of the medical history, what are the other medical conditions that he lives with? Does he have any coronary artery disease? Does he have diabetes? Does he have asthma or COPD or any cancer history or anything else going on that might be contributing to things? I'd also want to assess or consider the possibility of depression or a personality disorder or something like somatic symptom disorder, because those can be present in somebody who's eligible for MAID, but they can't at this time be the sole driver for a MAID request because they are underlying mental illnesses and not deemed to be medical illnesses for the purposes of MAID. I'd want to go through his thorough, back to the previous slide, his understanding of the request for MAID. How long has he been interested in MAID? When is it something that occurred to him, or when did he learn about it? How does the idea of MAID fit in with his longstanding values and principles? Want to explore his experience of his suffering. Again, it's suffering according to him. What does it mean to him? What has been the impact of the chronic pain on his life? What is his intolerable suffering? What can he do? What can he no longer do that gave his life meaning? Is he able to, as Sandip talked about, the ADLs, or the activities of daily living, and the independent activities of daily living? Is he still able to work? Is he still able to participate in hobbies? Is he able to participate in family life in ways that are meaningful to him? What does all that mean for him? What exactly is his advanced state of irreversible decline in capability, if there is any? So again, what can he no longer do that's important to him? He may still be able to do some things, but if he's not able to do things that are important to him or things that are necessary for him to live his life or to continue to work, then he certainly could be in an advanced state of irreversible decline. That also raises a question of who gets to decide what an advanced state of irreversible decline and capability is. And my understanding is that it's a clinical decision, but it's also a very personal decision on the part of the patient. So a patient who may be experiencing decline, it may be from their point of view, it may be severe and debilitating, whereas that same kind of decline for another person may not be. So I certainly take that into consideration in making that assessment. For somebody with a diagnosis like complex regional pain syndrome, I want to look at all the treatments that are available so that they can be offered to him if they're available in his area. And he has to know about them in order, and has to have access to them in order to be able to truly give informed consent for MAID. So that would include the medications and things that he's already tried, but there are also some other ones that I would add to that list. And next slide, please. So again, these are the eligibility criteria that I would want to make sure that Joseph met in order to be able to be eligible for MAID. And if he was found to be eligible, his death, because it's a chronic regional pain syndrome, it's not it's maybe a life-limiting condition, but it's not a terminal condition. So his death would not be deemed to be reasonably foreseeable. So he would be put on what we would call that track 2. And that would give the assessor that 90 days in opportunity to do the research that they need to do to make sure that all of the necessary information has been provided to Yosa so that he could truly make that informed decision. And if necessary, he could meet with a pain specialist or go to a pain clinic or something. Referrals could be made if there were some other things that he might want to try.
All right, thank you. Sandip, anything you would add to this case? Any observations? Oh, you're muted.
Yeah, no, I think pretty much exactly like sort of Dr. Perrot's approach. The one thing you always, with everybody, and especially somebody that necessarily may not have a life-limiting or a terminal illness, is you really want to make sure where does that motivation come from. As mentioned, all those other treatment resources, have they been offered them or not? And also with somebody who's young in this kind of situation with a family, with little ones, have they given that some consideration? Not that it should be their decision or guide them, say I can't or I can or can't because of the impact on others, but it is something that others in their family will be living with after. And sometimes, even if it's just for the fact of helping those discussions, as we talked about, have they talked with the wife or their family, how it would impact on the family, and how things that we can do to support them through that. And sometimes there's going to be a grieving process too. And so that awareness for other family members, with the patient's permission, of course, can be helpful. Because we're also remembering with MAID is not just impacts the patient themselves, but the family often are involved in caregiving. So they are also impacted by this decision. So we often encourage, but it's not a requirement, that their loved ones, be involved in the decision-making process, if they are, of course, comfortable with that.
And that also raises another point that often their family members and sometimes even friends will be involved in the MAID assessment interview. So I always tell patients that you're welcome to have anybody there that you would like, and often they will want family members to be there, or even sometimes friends. But there are some questions that I need to go over with the patient that I need to speak with them alone. So I always say there will come a time when I will ask you to step out of the room because I need to speak with so-and-so on their own. And that's when I explore for coercion and some of the more delicate aspects of the assessment process. But definitely other family members and friends can certainly be involved in the process. They have no say in the final outcome or in whether or not someone who's eligible can actually receive MAID, but they can be involved in the process.
Yeah, and just to add to that, and that includes even being at the time of the MAID. So sometimes family members will want to be present. So we will ask, as part of that planning process, to the patient, is there anybody in particular you'd want there? Your loved one, family, your pastor, somebody from, from your religious background, somebody from the church or temple, anything. It's left up to that patient to make that experience as meaningful for them as possible.
Sure. Great. Thank you both. So we're switching to some of the audience questions now. So somebody has asked for some advice. If somebody wants MAID in the future, they don't want it now, they're certainly not ready to go ahead with MAID, but they know that they want it down the road. What should the approach be for somebody in that situation? Sandip, do you want to get us started with that?
Sure. I guess there's, you can sort of break it down into two. Is there somebody that, would they qualify potentially for MAID and they just don't want a MAID right now at this stage in their life? Or would they potentially not even qualify? Emergency alert here, my apologies. Or is it somebody that potentially may not qualify, but they want to think about it in case they do acquire an illness or disease in the future, and then they would want to have it in place in case. So part of that, involves that sometimes there's preliminary discussions, maybe not a formal MAID request. Sometimes somebody like this, whether if they have a family doctor or a nurse practitioner, primary care provider, having those discussions, sort of where this comes up from, why is that thought coming up from, to help explore that. And in that exploration, sometimes you can get a feeling, okay, well, this person does have some illnesses, disease that potentially they may be eligible, and letting the person know, okay, well, they can formally submit a request and go through the process of some assessments now. It doesn't mean if they don't qualify now that they couldn't re-request or apply for it later. But going through that sort of, are they sort of looking initially eligible or not eligible, and helping you decide. In terms of advance request at this time being, if somebody was eligible, they couldn't, as per the legislation right now, put in an advance request saying, okay, when I get this illness or disease in this situation, then I would want it. So those personal directives that often people have, and there are different like power of attorneys in every provinces where you can specify what medical treatments or you would or would not want if you're unable to make that the decision. For MAID, that is not possible right now. There is work being done on a parliamentary review to explore that advanced directive piece, but as it currently stands, that wouldn't be something that people are able to do.
Anything to add, Chantal?
I think it's never too early in life to think about end of life care and think about what you might want or might not want. And certainly if somebody reaches a certain age or has particular illnesses, it's never too early to think about MAID and to think about applying for MAID or getting the assessment process in place. And as I mentioned before, I have some patients that I've followed even for a couple of years because they going through the MAID process can be pretty arduous to get the assessments done and learn enough about it so that you can make an informed decision. And waiting till the very end until things are in a dire strait, I think it's often too late and makes it very difficult for patients and for the clinicians. So if somebody says, I think I'm interested in MAID, I'm happy to meet with them and go over things with it and inform them about the MAID process and what MAID would be like and all of that. So it just gives them information. The more information they have, the better informed the decision can be made. And I may just tell them that this is part of the eligibility assessment process, but I'm not going to make a final determination until you're ready. So it's just it's a MAID request, but not a MAID determination. And so things just kind of roll along as they proceed.
Right. Okay, thank you. So we have another question as well about assessing for MAID when someone doesn't have access to resources in their life. And this person is wondering how that will factor into the assessment process. And Chantal, I'll get your thoughts on that. I know you're so well connected with the practitioner community, so it'd be great to hear what you think. But I also wanted to say that DWDC recognizes and is distressed by the lack of adequate resources in Canada and within the system, and certainly feel as though improvements and additional funding are so necessary in this country, and that people should be able to access these supports. I know when it comes to MAID and people moving forward with their requests, we also recognize that the importance of autonomy for those requests and trusting that individuals can decide when suffering has become intolerable to them personally. Some of you may have seen a an interview recently with Dr. Stephanie Green, and in that interview, she spoke about the need to work on support and resources and access to assisted dying in parallel, and that's certainly something that resonates with us as well. So, Chantal, anything to add to that or expand on?
It's a good question and an important question, and not an easy one to answer. You know, Canada is a huge country, and there certainly are disparities in resources available to people living in different parts of the country. In Toronto, we certainly have much more access to things than somebody living in northern remote communities. So, you know, in terms of a track 2 patient in particular, it's looking at what are the resources that are available to that person. And unfortunately, some resources are going to be available to a person in Toronto that are not going to be available elsewhere or in other parts of the country. And each determination of the choice for MAID from the patient's point of view, as well as their eligibility from the clinician's point of view, has to be made on that case-by-case basis. And as Kelly mentioned, or Kelsey mentioned, it's the person that gets to determine when their suffering is at the point that it's intolerable and cannot be relieved and in a manner that they consider acceptable. And that can be very painful for us to hear and to experience. And likewise, there are inadequate resources and services available to people across the country, including in Toronto. We can't always get what we need and want for our patients. And certainly as patients, we can't always get what we need and want. And we do need a lot more palliative care. We do need a lot more mental health services. We do need a lot more disability support services. We need a lot more home care services. And again, unfortunately, there are going to be disparities across the country in the availability of these things.
Thanks, Chantal. We actually got a number of questions. It's kind of interesting. I feel like we don't get too many questions about Parkinson's, but this webinar, quite a few people were asking about it. So Sandip, recognizing that we're talking very generally here, but how do you approach assessments for somebody with a Parkinson's diagnosis? Are there any special considerations there?
Not any sort of general approach would still be the same, but you know, obviously with every illness, you're looking at some particular details you want to look at it for. So the general approach about, you know, we talked about the guideline, the framework is still the same, but some of the things you want to look with Parkinson's, you know, is looking at the natural course. It's variable. Everybody's course with Parkinson's can vary when they get it, how quickly they're progressing, what stage they're in, other conditions that can sort of exacerbate or amplify, accelerate the process. So with Parkinson's, of course, there's, you know, physical decline. How is that affecting their ability to function? How is it affecting their ability to enjoy life? We talked about, you know, the things that you normally enjoy in life. Are you still able to enjoy those? So asking those questions, which are to everybody. But there's also, with a lot of neurological illnesses, and Parkinson's is no different, there is a cognitive component that can happen to it as well. So that includes things such as mental illness. So many people with Parkinson's can develop a secondary mental illness that can be in part due to the actual decline in functioning itself, but there can also be a secondary, you know, neurological component that can contribute to the mental health illness. So is that present? Is there any sort of depression overlying that? And lastly, with these neurological illnesses, the capacity. So people with Parkinson's can live a long life and still be able to make their full decisions, many of them right till the end. Others earlier on, they may develop some loss in their ability, their capacity to make decisions. So again, the approach would be still the same, but you might look at these things a bit sooner and more likely sort of have your radar up to look in a bit more detail with patients that may not have similar illnesses.
Thank you. So we have about 10 minutes left. We're going to try to get through a few more questions before we go. One for you, Chantal. So this person is wondering about a dementia diagnosis and after somebody has lost capacity. What we've gone over today is that you need capacity during your 2 assessments, and in some cases you can have a waiver of final consent. In some cases you can't. That's situational and something to talk to your MAID provider about. But if somebody has a loved one who has lost capacity, they haven't done assessments, it's unfortunately too late for them to move ahead with MAID. What options are there for folks in that situation who are caring for their loved one and are seeing them maybe not be as comfortable as they would have liked? What types of discussions should you maybe have with your healthcare providers about that?
So is this with the family member having the discussion or the patient?
Family member.
Family member.
Yeah.
Really, there is no option other than to continue to care for the person and provide them with whatever support to sustain their life you can. And if they were to develop, I mean, if the person has a do not resuscitate order, if the person who is the substitute decision maker or the power of attorney understands what the person would have wanted, and if they say that, well, the person never would have wanted to live in this condition, and if they developed a terminal illness, would they want to be treated? Perhaps not. They might be offered comfort care as opposed to surgery for cancer or stenting for heart attacks and that kind of thing. So it's determining, you really determine the kind of care that you would continue to provide to the person, giving them as much comfort as possible, but not necessarily treating acute illnesses. And that's where having an advance directive is really important. And to have talked to the person who's going to be your substitute decision maker or your power of attorney so that they would know what you would want. Some people right till the end want everything possible to stay alive. And this includes people who have severe dementia, that they would have wanted that, and they should be entitled to that. Whereas others who would say, if I can't, if I've had a mild to moderate stroke, or if I have mild to moderate dementia, or if I have A, B, or C, I would not want to be resuscitated if I had a heart attack. I would not want to be put on a ventilator. I would not want to have my pneumonia treated or my severe urinary tract infections treated. I would want to let nature take its course, meaning that they wouldn't want antibiotics necessarily for pneumonia, but they would want to be kept comfortable. They wouldn't want to be suffering or have difficulty breathing, so they would want medication that would help to alleviate whatever suffering. And that's really the best that can be done for people who's have lost capacity and it can no longer be assessed and be found eligible for MAID. And that also raises another point, just following up on Sandip's answer with dementia. When patients start to do, there are different forms of dementia, and it affects the brain in different ways, and it affects cognitive abilities in different ways. But when insight is lost, when the ability to appreciate what's happening to them is lost, and that happens more in Parkinson's than with some of the others, they may be able to do all kinds of things, but they may not really appreciate that they are on a downward spiral into further dementia and further decline. And so even though their values and principles may be that they would want MAID, they can't understand that they're really at the point now where they need to make that decision. And that can be very tragic particularly for the family.
Thank you. So we have a question from an attendee. How do I get an assessment to see if I'm eligible? My doctor says he hasn't heard of it. Well, I would recommend that your doctor take a look at our website and also check out websites of other organizations like the Canadian Association of MAID Assessors and Providers. There's lots of guidance for clinicians on their site. We certainly understand and respect that not all healthcare providers want to be involved in MAID, but we do hope and feel it's important that healthcare providers are aware of MAID as a legal option in this country. But how to get an assessment in each province and territory, there are care coordination services, and most of those you can access and contact without a referral from a doctor. So all of those are listed on our website, but do email us at support@dyingwithdignity.ca if you need any additional guidance there. So Sandip, a question for you. When you're assessing someone and you feel as though they might need additional interventions or resources or treatments, would you as an assessor make those referrals, or is it going back to their GP or their primary care provider and sort of working with them to make sure the person gets referred to where they need to go?
Yeah, so It can depend. It's unique. Ideally, if they do have a primary care provider, they have a good relationship with them. You want to connect with them. Part of the MAID assessment is not just about somebody makes a request. Okay, here you want a MAID. Okay, now we're going to do MAID. It's really talking about all things, assessing how they are doing, opening up all a much broader end of life options discussion. And part of that is, are there things, treatments, as you mentioned, supports available that maybe weren't offered, or that maybe the patient wasn't aware of, or maybe they're not available. You talked about, depending on where they are, maybe they're not available where they reside. Maybe there's some outside jurisdiction, outside service that could come in and provide, or the patient could be go to receive those. So for patients that do have a primary care provider and that are involved in it, we do encourage them, and we would share it. So if they're in a hospital or in a facility, we would discuss that with them. And share those advice with those primary caregivers, because they're going to be the ones responsible for following up on a regular basis. As a lot of the MAID assessors, they have outside stuff that they're doing. So when they do these consults, as much as they want to be actively involved, they're following. It's difficult to follow these patients on a regular, daily, or even weekly basis. So in order to ensure that those treatment options are followed through, we do want to connect with their primary care provider that they have. There's some that don't have any self-referrals. There's a lot of individuals, unfortunately, that don't have a primary care provider. In those cases, we would reach out to the other resources on behalf of the patient if they so desire. Again, this is one thing to remind, we talked about this earlier, is to stress it's the patient's desire and their decision. Do they want to pursue these other outside treatments and support services? We would list them, offer them, and then the patient would choose, yes, I do want to pursue these, or no. And if they do, most of the assessors are happy to make those links on their behalf for them.
Thank you. Chantal, is advanced age a non-reversible condition?
Yes.
Okay. Thank you. And one more for Sandip. Maybe we have time for two more, we'll see. How do people approving applications for MAID, how do assessors decide when one has chronic pain? I think this might be getting at who's determining the suffering of people trying to access MAID.
So when you're trying to, so chronic pain obviously is a very complex process. The experience of, pain in general for every patient is different. We have these various scales, but those scales, there's some objective, but there's definitely a subjective component to it. And again, as you pointed out, the suffering piece to that pain, what somebody perceives as severe pain, for somebody else it may be moderate, somebody else it may be mild. So perceiving that pain, a lot of it, relies on, trusting the patient when you're doing that assessment, what they're telling you, this is what I'm experiencing, these are my symptoms. And something like pain, you may not always see it. It may not be obvious just by visual glance, but when you talk to them, you see what they're going through, their functioning day to day, how it's impacting them, what supports they need. So there's a very comprehensive assessment about the pain. And, the central focus of course, is what the patient themselves reports to you. And sometimes getting that collateral for that too. Again, other healthcare members that might be involved in their team, family members that can kind of corroborate that. But essentially it relies on, like a lot of clinical assessments, especially in MAID, is trusting what the patient is telling you, because when they're making these requests, it's not, for most individuals, something that's just done very hastily. It's something after many, many years of, suffering, hardships, dealing with illness, disease, that they've tried many different avenues that haven't been able to find something that works for them. So, really putting some weight on their, what they tell you.
Okay, thank you. All right. 1 minute to go, less than that. So we'll probably wrap it up here. Chantal, Sandip, I wanted to thank you both for everything today. It's been wonderful to get your insight as MAID providers and assessors. And our attendees, there were a lot of you here today and a lot of wonderful questions coming through. We really appreciate that. If you could take a few moments to fill out the survey that will pop up on your screen, we would appreciate your feedback on today's session and ideas for future sessions as well. As mentioned, this is the first in a 5-session series, so we will be back all throughout May with other topics. And we hope to see you next week. The link to register is in the chat and it's also on our website. So please do register and we hope to see you back here then. Thanks again, everyone. Take care. Bye-bye.
Bye-bye.
Thank you, everyone.